Hey everyone, welcome back to Izzy Medicine, where we dig into the endocrine system until all the hormone confusion melts away. Today, we're talking about a gland that doesn't get enough credit for just how much chaos it can create when it malfunctions. Now let's imagine you're seeing a 48-year-old man, and he presents to you complaining that he's been progressively more tired, his libido has decreased significantly, he's been gaining weight recently, and he tells you that he used to work out regularly, but lately he's been noticing that his muscles are weak, he has less stamina, and also his erections have become less frequent. And his wife also noticed that he's been kind of more forgetful and more apathetic. And when you ask him more pointed questions, he tells you that, he's been having more frequent headaches. And he mentions that he's kind of recently started bumping into objects on either side while walking through doorways. So, what are you thinking? What's the problem here? If you thought pituitary gland issues, you're right. This tiny tucked away gland in the sella turcica is absolutely critical, and when it malfunctions, it can create a lot of trouble. So let's introduce it. What does this gland actually do? The pituitary is sometimes called the master gland because it controls the release of many other hormones in the body. But as we've learned from several lectures, it doesn't work alone. It's directly controlled by the hypothalamus. And the hypothalamus sends releasing or inhibiting hormones through the portal system, and the pituitary then sends out its own hormones in response to tell the other organs what to do. So if you think about the hypothalamus as the boss, the pituitary is the loudspeaker that yells what tasks need to be completed. The pituitary has two main parts. It has the anterior pituitary, which makes hormones, and it has a posterior pituitary, which doesn't make its own hormones, but it releases hormones made in the hypothalamus. Now let's zoom in a little bit and look at all this hormone-making action. The anterior pituitary is made up of several types of specialized hormone-producing cells, and each cell line has a unique role. Kind of think of them as hormone departments. Each one is focused on producing a particular signal, and it gets sent out to distant organs. So let's break them down. The anterior pituitary has somatotrophs, and somatotrophs are responsible for growth hormone. The lactotrophs, kind of as the name suggests, have to do with lactation, and they produce prolactin. Gonadotropes from gonads produce FSH and LH. Thyrotropes produce TSH, and cortotropes ACTH. And then we have the posterior pituitary, which again doesn't make hormones itself, but it is the release hub for two critical hormones made in the hypothalamus. The posterior pituitary releases ADH, antidiuretic hormone, and oxytocin. So each of these hormones has a very specific target and role, and if anything disrupts this system, the clinical effects are super dramatic. So let's start with hypopituitarism, and this is when the pituitary fails to produce enough of one or more hormones. There are two major ways that this can happen. It can happen through compression and through destruction. So let's review what can actually cause compression. The main cause of a compression to cause hypopituitarism is a macroadenoma. A macroadenoma is usually a benign tumor that's more than 10 millimeters in size. What happens here is that they grow large enough to physically compress pituitary tissue. They get so big that the pressure reduces blood flow and causes ischemia to all these hormone-producing cells, so it becomes dysfunctional. Additionally to this compression and blood flow and destruction of hormones, there's also another common sign that can happen with a macroadenoma, which our patient actually had when he was bumping into things and also having a hard time passing through doorways. This is called bitemporal heminopia. What happens here is loss of peripheral vision, and this is because the optic chiasm sits above the pituitary, and this optic chiasm gets compressed. And here's why. The optic chiasm is where the inner fibers from both eyes cross. These fibers carry information from the temporal outer visual fields because it hits from the outside and hits into the nasal portion of the retina. So when the macroadenoma expands upward and it compresses this optic chiasm, it disrupts these crossing fibers and it leads to loss of peripheral vision on both sides. It's kind of like turning off the side mirrors while driving and you're missing what's happening on the edges. Patients also have decreased space in their skull from this mass occupying effect from from this large macroadenoma, and this increases intracranial pressure and can cause headaches, which is another symptom that our patient complained about when we pressed for it. Now, if we don't have a macroadenoma that's compressing, the second path is destruction. And destruction of the pituitary gland can happen a few ways. First such way is Sheehan syndrome, which we discussed briefly here and there in different lectures. What happens here is during pregnancy, the pituitary enlarges and it becomes more vascular. And if a woman experiences severe postpartum hemorrhage, this drop in blood pressure leads to other complications, but can also lead to loss of circulation to the pituitary gland and causes ischemia and infarction of the anterior pituitary. After a couple of weeks, the patient may notice that there's failure to lactate, she can't breastfeed, she's exhausted, and may lose her menses altogether because several hormones were affected from this pituitary being completely destroyed. The other part is pituitary apoplexy. So let's say we have a pituitary macroadenoma. What can happen there sometimes is this macroadenoma suddenly bleeds into this space, and this bleeding causes sudden headache, sudden vision loss, and an acute adrenal crisis. And we discussed this in our adrenal lecture. Basic other things such as trauma, radiation, infiltrative disease, some autoimmune issues can also destroy tissue, but the story will be best told based on history. If it's a woman that recently gave birth and now is experiencing symptoms, that's one thing. If it's a patient that suddenly has a headache and symptoms and signs coinciding with hormone reduction, it can point to apoplexy. Now that we kind of know what the cell lines are and what happens when there's hypofunction either from compression or destruction, let's take a closer look at what actually happens when the pituitary isn't doing its job. What happens when each type of hormone producing cell stops working? So we'll go one by one for the anterior and posterior pituitary cell lines and connect the dots between the hormones, what they normally make, and what happens when it's missing. Somatotrophs produce growth hormone, and of course growth hormone plays a big role in growth and metabolism. Growth hormone travels through the bloodstream and tells the liver to produce IGF-1, which is insulin-like growth factor 1. Think of IGF-1 as a growth hormone sidekick. It's the one actually carrying out most of the tasks, like making bones grow longer and building up muscle and protein stores. So what happens in children, growth hormone and IGF-1 are both essential for height. They stimulate the epiphyseal growth plates in long bones. And without enough growth hormone, these plates don't get the signal, so growth slows and kids may end up with short stature or growth failure. So if you're in a pediatric office, for example, and you have a patient that you've been seeing for years and you're noticing that their height is under the growth chart and they're not growing according to plan, this is a good time to evaluate for possibly having growth hormone deficiency for pituitary reasons. In adults, they're usually done growing after puberty, and so even though linear growth is done, growth hormone helps regulate muscle mass and fat breakdown and energy metabolism. So if an adult gets growth hormone deficiency from pituitary hypofunction, they don't just feel tired. They might notice increased fat storage, and they might have reduced muscle tone. They might have low energy, low stamina. So that's something to think about. Our lactotrophs produce prolactin, and prolactin acts on breast tissue, specifically alveolar cells, and it stimulates milk production in response to suckling. So after childbirth, a surge in prolactin is what enables a mother to nurse. If the prolactin is absent, kind of like after Sheehan syndrome, and the lactotrophs are damaged, the mother may be unable to produce milk, and that's called lactation failure. So if you have a woman that recently gave birth and she's trying and she's already called a lactation consultant and she's gotten a hospital grade pump and it's still not happening, think about what has she experienced prior to this? Did she have a hemorrhage? Did she forget to tell us about it? Did we not get the medical records post delivery? Let's review and see what's happening here. There will be other pointers, like maybe amenorrhea and fatigue and other things to point to other hormones that may be suffering from this situation. So our gonadotrophs produce follicle-stimulating hormone, which is FSH, and luteinizing hormone, which is LH. And here the pituitary basically signals to regulate the gonads with these hormones. In men, FSH supports sperm production, and LH stimulates the Leydig cells in the testes to produce testosterone. In women, FSH drives follicular development in the ovaries, and LH is the key to ovulation and maintaining progesterone levels post-ovulation. So basically, when gonadotroph function is impaired, we see hypogonadism. And like our patient case, like our gentleman that came to see us, it can show up as low libido. It can show up as erectile dysfunction. It can also show as infertility because of decreased sperm production. So for example, this gentleman could have been a different gentleman who's saying that he's been trying to impregnate his wife. They've been trying for a baby for several months and nothing's happening. And then you send them for a sperm count and the sperm count is low. And when you're trying to figure out why and you ask more questions, he tells you, actually, I have been having headaches. And yeah, and my libido's kind of low, but we're still trying. And then you figure out that he has a macroadenoma of some sort. In women, you can have amenorrhea, menstrual irregularities, and infertility because of lack of ovulation. And estrogen and testosterone levels drop, and that can cause low mood, fatigue, and weight gain. Thyrotrophs are responsible for thyroid stimulating hormone, and it acts on the thyroid gland to produce T3 and T4. So these thyroid hormones regulate basal metabolic rate, and we learned this in the hypothyroidism lecture and in the hyperthyroidism lecture. And it basically regulates how fast the cells run their energy-producing machinery. So if TSH is low due to pituitary dysfunction, then T3 and T4 levels drop, and that's called secondary hypothyroidism, and everything slows down. Metabolism, GI motility can cause constipation, heart rate drops, nerve conduction can cause us to have slow reflexes. So the classic symptoms that a patient can come with is they can come with fatigue, some cold intolerance, weight gain, constipation, dry skin, depression, everything that kind of shows a slowdown situation. Our corticotrophs are responsible for secreting adrenocorticotropic hormone, ACTH. And this targets the adrenal cortex, and we learned about this in our adrenal insufficiency lecture. And this adrenal gland stimulates the production of cortisol. And cortisol is essential for glucose regulation and blood pressure maintenance and immune modulation and stress response. So if ACTH is low, the adrenals don't produce enough cortisol, and this is secondary adrenal insufficiency. We'll see fatigue due to poor glucose availability, low blood pressure, because cortisol helps maintain vascular tone, hypoglycemia, and hyponatremia. Now we have our posterior pituitary, which, as we said, doesn't produce its own hormones, but it releases hormones that are produced in the hypothalamus. So it releases antidiuretic hormone, ADH. And what ADH does is it acts on the collecting ducts of the kidneys, and it tells them to reabsorb free water back into circulation. So if we have ADH deficiency, such as central diabetes insipidus, the kidneys basically can't retain water. No matter how dehydrated the body gets, it still leads to polyuria. The patient is peeing a lot. The kidneys are dumping large volumes of dilute urine. Polydipsia, because the water is being dumped and the patient tries to keep up, the body's trying to rehydrate. And then we have hypernatremia, because water is being dumped without losing sodium, and this concentration gradient changes. Water leaves, sodium stays, and there's high sodium in the blood. It's kind of like a faucet is stuck open and the tank keeps emptying. No matter how much you drink, you're just trying to fill it, and it's just all running out. Okay, so we've seen what happens when the pituitary underperforms. Now let's kind of flip the script and see what happens when the pituitary does too much. That's hyperpituitarism. And most of the time, it isn't the whole gland going haywire. It's one rogue cell line out of the cell lines that we've discussed that goes off the rails. Usually the main culprit is a functional pituitary adenoma. These are benign tumors, and they arise from one of the hormone-producing cells in the anterior pituitary. But instead of destroying nearby cells like a big macroadenoma might, these tumors are usually small. They're microadenomas. They're under 10 millimeters. So, and they grow within a single line, like galactorrhea or somatotrophs, and the cells don't get compressed here due to sheer size. They get amplified. So instead of failure, you get overproduction. And also, because these tumors are small, they don't usually cause that mass effect that a larger tumor does. So we don't have vision changes, and we don't usually have a significant headache. It's just one hormone going wild, and the symptoms depend on which cell line it comes from. So let's talk about the most common pituitary adenomas. So a prolactinoma is the most common one. It makes up 40 to 50% of pituitary tumors. And as their name suggests, these tumors pump out excess prolactin. And what happens is normally prolactin is released during pregnancy and with breastfeeding to produce breast milk. But here, because there's a prolactinoma not related to pregnancy, women may experience milky discharge without it. Prolactin also acts on other gonadotropes, and it can cause menstrual irregularities and sometimes infertility. In men, where we don't usually have prolactin stimulating breast tissue, if they have a prolactinoma, they develop gynecomastia or breast tissue growth. It affects other gonadotropins and suppresses them, so they can have low libido and erectile dysfunction if they have this tumor. Somatotroph adenoma is where we have growth hormone excess. So in adults, this can cause acromegaly. So too much growth hormone leads to too much IGF-1, and that basically results in the facial features and the characteristic features of acromegaly. We can have thickened facial features, broad hands and feet, excess sweating, and some insulin resistance. And so you might have a patient come in, say, oh, my voice has gotten deeper. My rings used to fit, but they don't anymore. These shoes suddenly feel too tight. And some develop carpal tunnel syndrome and joint pain, and all of a sudden develop new onset type 2 diabetes. In children, on the other hand, where growth plates are still open, excess growth hormone can cause gigantism instead of acromegaly. So these kids may grow exceptionally tall for their age with long limbs, large hands and feet, and they may complain of growing pains. And if left untreated, the height can become extreme, and it can lead to complications like joint degeneration and cardiovascular strain. There are some basketball players that display this and have actually had a lot of issues with being athletes. For corticotroph adenoma, we can get Cushing's disease because we have ACTH excess. So ACTH stimulates the adrenals to overproduce cortisol, and patients develop that classic moon face, buffalo hump, abdominal stretch marks, central obesity, and skin thinning. And we discussed this in our Cushing's disease, Cushing syndrome lecture. For thyrotroph adenoma, it's very rare, and it can cause secondary hyperthyroidism. And the patient has signs of thyrotoxicosis, like heat intolerance, weight loss, tachycardia, and anxiety, but with an inappropriately normal or high TSH. So now that we've explored the chaos of hypo and hyperpituitarism, let's talk through how to actually work this up. We start with lab tests. If you suspect hypopituitarism, check levels of hormones from the end organs, like free T4 for the thyroid, cortisol for adrenal gland, estradiol or testosterone, IGF-1 if we're worried about growth hormone. But don't stop there. You also want to check upstream pituitary signals like TSH, ACTH, LH, FSH, and prolactin. If you see that multiple hormones are low and their corresponding pituitary hormones are also inappropriately low, that points to central or secondary causes, meaning the pituitary is underperforming. On the flip side, if you're dealing with a hyperfunctioning tumor, your labs will often show one hormone that's clearly elevated, like prolactin or IGF-1 or ACTH, and suppression of other pituitary hormones. Each overproduced hormone gives you a little clue to the cell line that has gone rogue. Once you've got lab evidence, you move on to imaging. So what we do is an MRI of the brain with dedicated pituitary protocol. That's the gold standard. And this will show you whether there's a macroadenoma that's more than 10 millimeters or a microadenoma that's less than 10 millimeters, whether it's pressing on surrounding structures like the optic chiasm, or even if we have a partially empty cella turcica in the case of destruction from Sheehan syndrome or pituitary apoplexy. For prolactinomas, first-line treatment is medical. So usually a dopamine agonist like cabergoline or bromocriptine. These shrink the tumors and reduce the prolactin levels effectively in most patients, and often this avoids the need for surgery. For non-prolactin secreting tumors, especially if there's visual loss or significant mass effect if it's a macroadenoma, The treatment is usually surgical, a transsphenoidal resection to remove the tumor. Some patients may require postoperative radiation therapy or long-term hormone replacement, depending on how much normal pituitary tissue remains. The bottom line is that diagnosing pituitary disorders means that we have to pay attention to patterns. And when multiple systems start malfunctioning at once, metabolism, reproduction, mood, fluid imbalance, don't forget to look upstream, and because the pituitary might be the hidden player behind it all. All right, guys, that's a wrap on pituitary disorders. I had fun teaching you. I hope you had fun learning. And I will see you hopefully in the next lecture. If you enjoyed this content, if you found it useful, please like, subscribe, leave me a comment so I can answer some questions. In the meantime, stay curious, and bye, and thank you.